Good afternoon, everybody. My name is Deborah DeBruin, and I direct the Center for Bioethics here at the University of Minnesota, and I want to welcome you all to today's webinar. We're really delighted to be able to host Dr. Lisa Iezzoni for this important conversation today. Before we begin, I just want to note that I have one of my colleagues co-hosting with me today, Professor Joel Wu, and he will be sort of helping out as needed during today's event. I unfortunately had my furnace die and have a heating contractor here installing a furnace right now. So if it gets too disruptive here in my venue, then Joel will take over hosting. A few housekeeping items before we introduce our esteemed speaker today. If you have questions for Dr. Iezzoni, please use the Q&A function, which you'll find at the bottom of your screen, to either ask or to follow up on questions. You can also use the Q&A function to let center staff know if you're having any sort of technical difficulties, and they will be able to manage those with you through that functionality on Zoom. Today's event is being recorded, and the recording will be posted to the center's website within just a few days. We ask that you take a few moments to fill out an evaluation on today's event if you could after the event is over. There are 3 ways that you can access that evaluation. It will pop up in your web browser once the Zoom closes at the end of the event. And if you choose to fill it out immediately, you'll have it handy there. It's also linked in the presentation details document, which Kayleen has just posted to the chat so that you can access that. That document has a lot of information about today's event all in one place. You will also receive an email after the event with a link to complete the evaluation if you don't have time to do it right away. And that way you can come back to it later at your leisure. Next slide, please. There are 3 groups of people who can get credit for today's event. Health professions students here at the University of Minnesota can get interprofessional education credit for attendance at today's event. Those students should not only be present for 75% of the event today, but please complete the reflection form that's located in the presentation details document. It's linked there, and then we will facilitate your getting credit for today's event. For professionals who would like to seek continuing ed credits, we will provide you with certificates of attendance so that you can apply for CEUs. Information about that process is also linked in the presentation details document. Finally, biomedical engineering students can email your program. You'll see the relevant email address on the slide. It is also included in the presentation details document. And if you contact your program and let them know that you have attended, they will facilitate your getting credit for attendance at today's event. Next slide, please. Those of you who are regulars to Ethics Grand Rounds know that the Center for Bioethics partners with other university programs on all of our programming, and we are always very, very grateful for that partnership. It really does help to make Ethics Grand Rounds possible to bring to all of you. So we'd like to thank the partners for today's events, our co-sponsors, the Medical School, the College of Pharmacy, the Program in Health Disparities Research, the School of Public Health, the Center for Race, Indigeneity, Disability, Gender, and Sexuality Studies, and the School of Nursing. Next slide, please. So without further ado, I would like to introduce Dr. Iezzoni. As usual, I'm going to give a very, very brief introduction to her today. You'll find her full bio linked in the presentation details document so that you can find more information about her. But I want to leave as much time as possible for her to present to us today and engage with us in discussion. So I will just say Dr. Lisa Izoni is professor of medicine at Harvard Medical School, and she's based at the Health Policy Research Center in the Mongan Institute at Massachusetts General Hospital. Dr. Iezzoni has conducted numerous studies examining the healthcare experiences of persons with disability. Today, she's here to present to us on physicians' experiences with and perceptions of caring for patients with a disability. It's a really important topic, and we are very grateful that she is taking time out of her busy schedule to be with us here today. At this point, Dr. Iezzoni, I'm going to turn things over to you.
Okay, and I'm going to try to share my slides. That's always the first thing that people do. Hold on a second. And I'm delighted to be here, Dr. Bruin. All right, so let me get started. I have no financial disclosures to report. Now, many of you know that every 10 years, our federal government goes through a process of looking at what the public health needs are for the population for the next 10 years. And this is the cover of what is called the Healthy People Initiative that came out in November of 2000, focusing on the next decade up to 2010. And this was the first time that this decennial Healthy People Initiative included people with disabilities among the disparities population. And what was really interesting about it was that they didn't just say people with disabilities have disparities, but they actually attributed these disparities to erroneous assumptions about the daily lives, values, and expectations of people with disabilities. They said that there are common misconceptions about people with disabilities that contribute to these disparities, especially an underemphasis on health promotion and disease prevention activities. Now, I have very limited time here today, so I'm not going to talk to you about the person-centered projects that I've done, but I've basically spent a lot of research time being privileged to speak to people with disabilities. I love doing the interviews myself. I don't know whether, many of you probably know that I am a wheelchair user, have used a wheelchair since 1988, and so I am part of the disability community. And so that's one of the reasons I love doing the interviews myself. And I've interviewed probably over 300 people with different types of disability. And I thought, just to convince you that there are disparities, that I would summarize findings from a series of R01 and R21 NIH grants that I've done. This one happens to be on breast cancer, but there's certainly other research out there on reproductive health and primary care, if you care to find it, that is person-centered. Okay, so breast cancer. We know that women with disability have lower rates of mammography compared to non-disabled women, although this disparity does differ by type of disability. There's not consistency across disabilities, but in general, mammography rates are lower. We know that women with disabilities who have early stage breast cancer, where breast conserving surgery and mastectomy could be equivalent in terms of disease-free survival, women with disabilities have significantly lower rates of breast conserving surgery than do other women. They are much more likely to have a mastectomy. Among women with breast conserving surgery, they have similar disease-free survival as those with mastectomy if they get radiation therapy after their surgery. However, among women with breast conserving surgery, women with disabilities have much lower rates of this radiation therapy. They also have lower rates of axillary node dissection to be able to assess whether they have metastatic disease. So these are both very troubling and may probably contribute to the high mortality rates for women with disabilities, not only all-cause mortality rates, but also excess mortality rates relating to their breast cancer. And I recently led a project that found something I didn't expect to find given the database that I was using, but we found it. And that is that even after you control for mammography use and sociodemographic characteristics, women with disability have higher rates of getting breast cancer than do other women. So there's lots of potential causes for these kind of disparities. There could be competing priorities from complex other health conditions people have. We know that people with disabilities on average have disadvantages and social determinants of health. People with disabilities may have different preferences than other people do. As we'll talk about in a few minutes, they face a lot of barriers to physical access and effective communication when receiving healthcare. However, there's also inadequate training of healthcare professionals. And I recently did a review article from around the world. And one of the reasons that people with disability are less likely, again, around the world to get breast and other cancer screening services is because their doctors just don't recommend them. Physicians have inadequate knowledge of the Americans with Disabilities Act or the ADA and their obligations to patients under the ADA. And they also, as Healthy People 2010 said, they make erroneous assumptions about people with disability and their health. So several studies have examined physicians' attitudes and behaviors toward people with disability, but generally they've been single site projects or else limited to specific geographic regions. And we were the first study to actually look nationally at physicians' experiences with and perceptions of caring for people with disabilities. So we were fortunate to get funding from the Eunice Kennedy Shriver National Institute of Child Health and Human Development. Now, those of you who are survey scientists in the audience, and I'm sure there are some, will know that surveys need to be short in order to bolster response rates. And if you want to get in good journals, you have to have a response rate of at least 60%. So our survey had to be short. And so therefore the survey went shallow, but not deep. We could not ask many follow-up questions to understand why. And I've already gotten a number of questions from some audience members, and I just won't be able to answer all of them because unfortunately, we just weren't able to ask all the questions that we would have liked to have asked in the survey. Okay, we were focused on physicians who care for outpatients and care for adults in their outpatient practices. We focused on 7 specialties where barriers to care and communication was going to be a big issue: internal medicine, general internal medicine, family medicine, rheumatology, neurology, ophthalmology, orthopedics, and obstetrics gynecology. Resource constraints prevented us from having enough participants to be able to do statistically rigorous comparisons across the physician specialties. So briefly, for survey development, we try to follow best practices, and I'll talk about this some at the very end of my talk. I personally conducted in-depth individual interviews with 20 practicing physicians in Massachusetts, and I'll talk about why that was actually important at the end. We also conducted 3 focus groups with 22 practicing physicians across 17 states. This allowed us to identify key topic areas for surveys and for the survey, and we designed the survey iteratively with a team, every 2 weeks, kind of getting together and looking at what the survey scientists experts said and what we content experts said. Then we did 8 cognitive interviews and 50 pilot tests of the draft survey, and the final survey instrument has 8 modules and 75 questions. I'm happy to send it to anybody who wants it. The modules were basically characteristics of the participants' practice. And then we looked at 5 different types of disability and a question or 2 about each. Chronic mobility limitations, vision limitations, hearing limitations, serious mental illness, and then significant intellectual disability. We then had a module around the Americans with Disabilities Act and kind of other stigmatizing issues. And then we asked physicians about their demographic characteristics. So to conduct the survey, we bought a national list of doctors and we randomly sampled them. We eliminated trainees, VA physicians, hospitalists, locum tenens physicians, and physicians no longer practicing. We sampled 1,400 total physicians. As you can see, they're split between primary care and the specialties. The Center for Survey Research at UMass Boston was our survey contractor, and they mailed out the paper survey in October of 2019 with a crisp $50 bill included in it. And for those of you who've ever tried to survey physicians, the only way you can get them to respond is to pay them. And so we lost a lot of money because we didn't get 100% response rate, and only about 10 physicians respond to $50, but we needed to do that to get our response rate up. And we had two options for physicians, either completing the survey on paper or online. And guess what? The vast majority did it on paper. Okay, so the Center for Survey Research had information to track respondents, which they started to do. We ran into a little bit of problems with the pandemic. You can see there that 84% answered by mail, which is kind of amazing. The UMass Boston, the governor of the state closed the University of Massachusetts campus in like February or March of 2020 and would not allow the survey scientists into the mailroom to see what was happening in terms of receipt of responses. So that was a little bit of a problem, but we closed the survey in June of 2020. We had an overall weighted response rate just over the line of 61%, although it varied narrowly across specialties from 58% for neurologists to 63% for rheumatologists. Okay, are there any quick questions, clarifying questions about the methods? Or is that pretty straightforward? Okay, all right. Any quick questions, Deborah, Dr. DeBrun? Okay.
I'm not seeing any questions.
Not seeing any. Okay, overview of results. Again, I'm going to try to go fast so we can have plenty of time for questions. So again, this is a national survey of physicians. And so the personal characteristics that you see here are the characteristics, the demographic characteristics of physicians nationwide. And I say that because you will see that most of the participants were male, 62%, 64% were white, 17% Asian, 18% were Hispanic, African American, or other races and ethnicities. 89% were urban, and 66%, or 2/3, had spent more than 20 years practicing since graduating medical school. Okay, starting with results. The ADA, the Americans with Disabilities Act, which George Herbert Walker Bush signed on July 26th of 1990. Okay, so it had been in effect for 30 years at the time we were conducting the survey. So the ADA requires people with disabilities to receive equal quality of care as other people, and this might require provision of reasonable accommodations. So 36% of physicians reported knowing little or nothing about their legal responsibilities under the ADA when caring for patients with disabilities. Again, 30 years after the ADA went into effect. 71% of physicians did not know the correct approach to determining reasonable accommodations, and 20% did not have correct knowledge about who pays for accommodations. By the way, the correct way to determine reasonable accommodations is for there to be a collaboration between doctors and the patient with a disability, for the two to talk to each other. And in public sites like city hospitals or county hospitals, the preferences of the patient, that's Title II, those are Title II facilities under the ADA, the preferences of the patients are supposed to take precedence. And in Title III facilities, those are private facilities, the accommodations are supposed to consider what the patients want. And in terms of who pays for the accommodations, the practice pays for them. Okay, 68% of physicians report at least some risk of having an ADA lawsuit against their practice because of accommodation problems. So First, throughout my talk, I'm just going to give you a few little examples from some of the patient interviews I did, so you can get a sense of what barriers might mean for patients, because most of you probably, this is not your field of interest. So this was a woman who had early stage breast cancer, needed to get a dose for chemotherapy, which she was going to need for treatment. And typically doses for these kind of chemotherapies are based on body surface area, which is height and weight. But the clinic that she was going to at a big, huge academic medical center did not have a wheelchair accessible scale. And she was a wheelchair user from a spinal cord injury. So to get the weight, my oncologist lifted me out of my wheelchair and held me in his arms to measure my weight. All right, so we asked in the mobility section about whether physicians use wheelchair accessible weight scales for patients with significant mobility limitations. And only 23% reported that they always or usually use accessible weight scales. Now, the vast majority, when you combine this, 32% always or usually, and then 40% just simply sometimes, just ask the patients their weights. Now, this is not a good idea, because research suggests that patients who use wheelchairs significantly underestimate their weights. And I can tell you from having interviewed a bunch of people with spinal cord injury, when I say, tell me, has anybody ever taken your weight? And they say, oh, I weigh what I did when I had my spinal cord injury, wink, wink, nod, nod, even though it might be 30 years after their injury. Okay, so this is an Olympic event being undertaken by this woman with spina bifida who approaches a fixed height exam table using her crutches. She then twists her body, and then she sits down on the exam table. Okay, she's very proud that she has the upper body strength to be able to do this with her crutches. But if I told you the truth about this, which is that at this point, this woman is 22 weeks pregnant, how would you feel about the fact that she has to get onto an exam table in this way? All right, so there are height adjustable exam tables where you can automatically, using a foot pedal or some other device, you can raise and lower the exam table for easier transfers for people who have significant mobility disabilities. Now, in total, only 40% of physicians always or usually use these height adjustable exam tables, and it's especially low for primary care doctors. Just a little over a third of them, or 36%, always or usually use height adjustable exam tables, whereas specialists, almost half of them do. Now, if they don't have a height adjustable exam table, 86% of them never use a lift device, which means that oftentimes they may not be getting their patients onto exam tables. But if they want to, a lot of them always or usually 40% and 45% sometimes get help from the person accompanying the patient, which is forbidden under the Americans with Disabilities Act because of risks of injuries and liabilities. And it's just simply not a good idea. Okay, so this comes from focus groups that we did with blind people. They don't really know how to hold on a second, let me just move this because I can't remember what that word was. How to deal with a blind person. Instead of coming up and saying, I'm so-and-so, and taking the time to show you the way, they grab you, they snatch you, they push you around the shoulders. It's embarrassing. So we asked physicians about their care for people with vision limitations. And so remember I told you before that I've interviewed 300 patients, and so I thought I kind of knew everything, and that interviewing the doctors wouldn't give me a lot of new things to ask the doctors about. I felt like I already knew that. Well, that wasn't true. When I interviewed the 20 Massachusetts physicians, I asked them about giving out printed materials to people who are blind, and the vast majority of them said that they couldn't print out things in large font, which was kind of astonishing to me, because people who have low vision often can compensate if they are able to use a document that is in large font. And so 56% of physicians rarely or never give out to their patients who are blind or have significant difficulty seeing, even with glasses, written materials in large font. And also 50% rarely or never verbally describe the exam room. Okay, this comes from some focus groups that we did with one of my early projects on primary care, where we had a deaf interpreter speaking sign language to ASL users, and we hearing people were sitting in the back of the room with somebody translating for us. And this was Kate. She was in her early 20s, and she had gone to her doctor for her first pap smear. And her doctor did not hire an ASL interpreter to help her. And so she gets up on the exam table and quote, "They didn't tell me what they were going to do. There I was in the stirrups. I couldn't see what was going on. The doctor didn't say to me, this might be uncomfortable, or tell me how much pain to expect." So when they inserted this, the doctor inserted the speculum, Kate had no idea that this was going to be about to happen. And I never went again. So this is from another focus group. We had women and men, and this was Harry, who's second generation deaf. His parents were also deaf. I was scared, and he was talking about a testicular or raped, or if this was a sexual event. A hearing doctor with a hearing patient will talk through the entire exam. But when the patient is deaf, again, this doctor refused to hire an ASL interpreter. They just do it. Okay, so accommodating people who are deaf. This was pretty astonishing to me. 50% of doctors said that they never, ever hire a sign language interpreter to come to the room with the patient. And 63% never use video remote sign language interpreters. And let me just interrupt myself to say that when you talk to sign language users, this is what they want. They prefer to have an interpreter in the room. They'll, go with a remote video sign language interpreter if it's necessary, but they want sign language to be able to communicate effectively with their physician. Instead, 50% of physicians simply always or usually speak louder or slower. Almost 50% just simply always or usually speak to the patient's companion. And 33% always or usually just use notes written on paper. Okay, so we asked physicians how confident they were in their ability to provide the same quality of care to patients without disabilities as you provide to other patients. And we looked for the top box here for a very confident, and only 42% of physicians said that they were very confident that they could provide the same quality of care to patients with disability as those without. Okay, so we also asked to get a perception of attitudes, these assumptions about people with disability compared to persons without disability. Do you believe the overall quality of work of life for people with significant disability is? And you see the response options here. These are not weighted responses, but once you weight the responses, 82.4% of doctors feel that people with disability have worse quality of life than other people. Let me pause for a second to say this is very, very troubling. For those of you who remember early during the COVID pandemic, states were getting out their crisis standards of care about who would be put to the back of the line if there were scarce resources like ventilators or ICU beds. And guess what? It was people with intellectual disability, people like me with neurodegenerative disability, probably because of perceptions about worse quality of life. And the Department of Health and Human Services in Washington, D.C., actually in March of 2020 had to issue a civil rights edict saying that you cannot make assumptions about quality of life and use that to determine what services you give people. Okay, so only 57% of physicians strongly welcome people with disabilities into their practice. Now, we asked about formal teaching and training, and just 8% of physicians said it was a large barrier, but 28% said it was a moderate barrier. And so if you put those two together, it's more than a third of physicians. We asked about lack of time. This is something whenever I talk to doctors' office, audiences, they always say, oh, we just don't have enough time. Well, about 14% of doctors said it was a large barrier, and 31% said it was a moderate barrier to caring for people with disabilities. Then we also asked questions about, given the broader healthcare system, how would you rate the quality of care for people with the 5 different types of disabilities we were looking at? And here I'll just give you 2 examples. The mobility disability first. 55% of physicians, when you add those 2 up, think that people with mobility disability have a little worse or a lot worse care than other people. The place where this was really, really a problem was for serious mental illness, for people with disability from serious mental illness. 77% of doctors think that people with serious mental illness get worse quality of care than other patients. And then this final slide is a picture of a paper that appeared in the October 22 issue of Health Affairs, which was a theme issue on disability. They did a great job kind of putting together a diverse set of articles. And we were fortunate enough to have this article appear in the journal. And this article is probably why you invited me to give this talk. Dr. DeBruin, I'm not going to put you on the spot for this, but this is the article that generated a front page New York Times article and an Atlantic article and Boston Globe article. But this was the article where we were talking about results from, and Tara Legoo, my colleague from Northwestern, who's a wonderful internist and colleague on this project, was talking about results from the focus groups that we did in 2018 to design the survey. So I always like to focus on the numbers, but the thing about the focus groups that happened before the survey is that it gives you a little bit more texture, since the survey had to be brief about why doctors might be saying some things that they said. And it was pretty appalling. That's why it ended up on the front page of the New York Times, because physicians during the focus group, and I moderated the focus groups, and I can, just have my face be blank during the focus group. And when a physician says something that was troubling, I'd say, oh, that's interesting. Tell me more, so they would say more things like, well, we think people with disabilities are entitled. We think that they think they'll do everything. We think that it's just ridiculous that they have a service peacock, for example, like a service animal as a peacock. Let me just interrupt myself to say that healthcare settings are very specific about what species are allowed as a service animal, and it's limited to dogs and sometimes to miniature horses, because there are some cultures that do not like dogs to be inside of a building. So miniature horses can sometimes be allowed. But there also was some troubling language about, oh, we figured out how to get rid of patients with disability in our practices because we don't want to care for them. They would lie about not taking the patient's insurance, or they would say to the patient, oh, you're too complicated. You really need to go to see somebody else. So there's a lot of attitudes out there that are ableist that really do, now in 2023 need some attention. So these are citations for the papers that we published relating to the survey, not all of them, but a lot of them. And you're going to be able to get this on PDF if you want it. And now let me pause for questions.
Thank you so much. That was so interesting, and I'm sure we're going to have a very rich discussion. And I am just going to say that it was so overdetermined why we wanted to invite you, because you have so many wonderful papers.
Well, whatever. I know, but
So,
this one, all of a sudden, my
got a
email
lot of
box
attention.
lit up.
Of course. Yes, yes, it got a
Uh,
lot of attention. I will
okay.
say what I neglected to say when I was doing the housekeeping conversation before I introduced you, that that presentation details document that Kayleen put together to provide people with background information and information about credit and so on for this talk also contains links to 3 of your papers. So if folks are interested in doing some extra reading or taking a look at some of that literature, you have that lovely list of citations there from Dr. Iezzoni, folks in the who are participating with us today, but there are some that are linked straight through to articles so that you can have a bit of an easier time reading through some stuff. So without further ado, we have lots of questions, so let's get to them. I think this is going to be a really interesting conversation, and I want to start with one, if I could, that came in before the talk. And just invite you to comment on this. We talked about this a little bit before the talk began today. This is from a patient who says, as a quadriplegic with very specialized care, it's important that I be allowed to have my own specially trained PCAs, personal care attendants or assistants with me in the hospital. The doctors and nurses agree, but at times there have been rules coming down from management that PCAs not be allowed to stay overnight. We have often had to fight to keep them with me. One time the management would not budge. My doctor actually discharged me early because she knew I would be safer at home with my PCA than in the hospital without her, even though it meant foregoing a needed blood transfusion scheduled the next day. Something that hospital management should definitely consider, says the patient. I just want to invite you to reflect on that experience. I think there's so much really incredible information you provided in your talk, but the quotations from the individuals were very striking, and the
Yeah,
photos. Yeah.
yeah, that's why I wanted to include that. Well, it's just a heartbreaking story that this person tells, but sadly, it's not unique. And we were talking about this a little bit before we started at what time? Oh, noon, 1 o'clock my time. Um, and let me just say that this was something that we actually confronted here in Boston. So um, starting in 2006, Greater Boston Legal Services combined with Boston Center for Independent Living, every kind of place around the country has centers for independent living, which are federally funded under the Rehabilitation Act of 1973 was when they started, that are advocacy organizations and peer support and peer counseling organizations for people with disabilities. And in Boston, Greater Boston Legal Services and BCIL, Boston Center for Independent Living, got together to go to hospitals to say to them, look, you know, people with disabilities are having trouble with the care that you're giving to them. Here are some of the problems with quality. And that was one of the exact issues that was raised, was not being able to have your personal PCA with you at the time. And you know, a lot of it did come down from management. It was kind of legal liability issues. Hospitals are dangerous places. Even if you're quote unquote just a person walking through, you're at risk of tripping over, you know, a spill on the floor, or getting an infectious disease. And so hospitals are going to be cautious. Management at hospitals are going to be cautious about things where they think that they could have a legal liability. But working with Greater Boston Legal Services and BCIL, we were able to convince hospitals to change their rules and be able to allow a PCA who is trusted by the patient to be with the patient at the bedside. There are some other considerations that might be at play here. For example, Medicaid is the major public payer of PCAs, and Medicaid often will not pay for a PCA to be in the hospital because they assume that there are other people in the hospital who can do that support care for the patient. So the state Medicaid program may not be paying for that person. And that's something that you also need to consider. But I think then the final thing that I would say about this, and this does not sound like the case here, and so I just want to underscore that this sounds like a person who is quadriplegic and has wonderful relationships with his or her, their PCAs. But people with disability are at high risk of intimate partner, domestic violence. And some of that can be from PCAs. I have and some of it can be really subtle. I have a dear friend who's a man, whose live-in person would torture him by keeping his cell phone about an inch or two away from where his fingers could reach it. And he's quadriplegic. And so he couldn't reach his phone to be able to call if he needed help. And so even small, things like that can be really abusive. And so you want to make sure that a PCA, if that PCA is going to be at the hospital bedside or is going to be in the room with somebody, that you somehow as a caregiver, as a professional caregiver, have been able to determine that the patient is comfortable and trusts that person and is completely open and willing to have them in the room with them.
Great, thank you for that detailed reflection and response. I'm going to have to step in because Professor De Bruyn's furnace situation has escalated. So I think a related follow-up question here is about the relative obligations of institutions as opposed to the specific clinicians. So this person asks, what is the responsibility of a practicing physician versus that of the institution or employer to understand the ADA and address needs appropriately? This person goes on to say, in my experience, physicians have little input on management and the resource practices of the clinics in which they work. And they also wonder, have you considered or have you had experiences that might inform what's going on at the administrative or organizational level?
Well, we actually got, when we published the paper on the ADA, we actually got a letter to the editor about that exact topic. It was somebody saying, we work for a big hospital delivery system and they don't listen to us. And our response was, that's a problem because you are not able to give the same quality care to your patients. And if you are working at a place that does not support your ability to give the same quality care to your patients, number one, that place is at risk of an ADA lawsuit. And, I don't like the litigious in American medicine, but I find it actually pretty horrific. But we are 33 years now after the signing of the ADA. And at this point, we need to have settings that are accessible and communication approaches that are effective. And let me just say that one of the things that I always, repeat over and over again, and so those of you who have heard me talk before, well, this will sound familiar to you. When we talk, for example, about height adjustable exam tables, there's a win-win-win here, okay? There's a win for the person with a disability if they can more independently transfer and more safely transfer onto an exam table. Secondly, physicians come at different heights. There are physicians who are shorter and there are physicians who are taller. And so for physicians, being able to adjust the exam table at a height that is ergonomically best for them, and nurse practitioners and physician assistants, and so everybody who has to do a physical exam, if they can adjust the table at a height that's better for them, it's going to make them less exhausted at the end of the day, and it's going to allow them to feel that they're giving a better exam. And then the third thing that I would say is that according to the Occupational Safety and Health Administration, a federal agency, one of the occupations with the highest rate of workplace injuries are practice assistants, nursing staff, CNAs, and that comes from transferring patients. And so if you're having staff have to go out and you're having to replace them because they have a back injury from transferring the patient, and it could be helped if you have a height adjustable exam table, again, there's 3 types of wins that you have there. And so let me just say also for small practices, not for the big ones, but for small practices, you can get tax credits for getting accessible equipment. And so you should explore that. If you're a small practice and want to get a height adjustable exam table, you can get a tax credit that will defray your costs for doing that.
Great. And that really is a thoughtful sort of emphasis that there is not necessarily any downside for an organization or institution. You reduce liability, you reduce injury, and you also create the conditions to provide the best kind of care for patients and people with disabilities. So
yeah, and Joel, at risk of knowing that I'm going to reduce the number of questions that can be asked, I want to say one more thing, and that is that in my practice, they finally got a height adjustable exam table. And so I very innocently rolled in one day and I asked the practice assistant, so how do patients like the exam table? And this is exactly the words that she used in responding to me. So the language is not going to be what I would say, but it is what she said to me. The little old ladies love it. Okay.
oh
The fact that we are going to have a lot more older people who it's going to be easier for them to just sit down on the table. And so if people are thinking in a marketing sort of way, at every age range, people are going to be seeing more people with disabilities. And so it just makes sense to accommodate them.
Right. So let's move to a couple questions that are more specific to your survey, this research that you described. One question asks, being that the survey results were from physicians primarily in urban areas, how do you think these results would differ for rural physicians? They sort of wonder if the results would show that there might be even more disparity in rural areas.
Yeah. Okay. It's a great question. And again, this was a national sample. And so this is the national distribution of physicians. However, that does not mean that the question you ask isn't appropriate and very important to answer. I've done some qualitative work where I've interviewed patients or people with disabilities in rural areas. And so from the person with disability in rural area perspective, it's a problem because number one, transportation, they can't get to the practice if they can't drive themselves. Number two, often the facilities are older, and so they're less likely to be accessible. They're more likely to be very small practices, and the facility might be too small to, be able to have space for a wheelchair accessible weight scale. But we also, those 3 focus groups that we did to design the surveys, we intentionally had one focus group specifically with rural physicians. And we heard some pretty amazing things like, well, if I have a wheelchair user whose weight I need to get, and I don't have an accessible weight scale, I send them to the cattle processing plant to be weighed on the scales that the cattle processing plant has, or I send them to the grain storage facility. And so this was kind of worrisome as well. For urban physicians, we've heard people be told to go to the post office to be weighed on the scales for, boxes, but there definitely will be some differences in rural areas. Yeah.
Right. So just to say, one of the interesting things is that the distribution of either the opportunities or some of the barriers may not be even across different parts of community for different reasons. Right.
Absolutely.
A related question was, were you surprised that some specialties who should know more about a particular disability, like ophthalmologists who are not particularly accommodating or have a limited understanding of the effects of visual impairments, do they do better? Do they do worse in providing accommodation?
No, they they didn't. And as I said, we weren't able to power up to be able to have rigorous results across specialties, because surveys are really expensive to do. And this was an NIH project, and this is kind of in the weeds. But for those of you who know NIH, you can't get more than, $500,000 in direct costs a year. And so we knew that we needed to have our survey be a certain size. But we did in a JAMA ophthalmology paper that is in the list at the end. We did actually pull out ophthalmologists to see if they did any better. Guess what? Not really. Especially when it came to, showing patients their exam rooms or walking them through and saying, let me just introduce you to the exam room, or giving, large font materials. And I had somebody who self-introduced as a head of some ophthalmology professional association call me up and say, why did you ask if they can show the patient into the exam room? And my response was, because that's what patients who were blind told us they wanted. And so to have somebody from a professional association call me and question why we asked about this, and these were things that patients had told us they wanted, was actually kind of interesting.
I want to transition to some broader questions here, just to really sort of get your wisdom here. This person's question says, my question is simple. How do we untrain or get rid of some of these attitudes that are embedded so deeply in physicians and also in many non-physicians? I think they're referring to, in particular, these differences in our views of quality of life, right? How do we start to address this?
Yeah, exactly. Well, I think there's both implicit and explicit bias going on here. And so I think that the explicit bias, we can call it out when we see it. But the implicit bias is where it's going to be a lot harder. And I think that it's going to be challenging. It's going to be hard to do, because our culture is just a culture of being physically fit and vigorous and being able to kind of pull yourself up by your own bootstraps. And, there's incredible ambulatory metaphors throughout our entire language, and I think that this is going to be hard. We can start in medical school, although there is an implicit association test. People know about implicit association tests for looking at implicit biases for racial and ethnic minorities. There is one for disabilities, and a colleague of mine administered that to first and second year medical students, and guess what? Found that they were just as biased as other people were. And so I think that there's a tiny bit of research about this, and one of that shows that hang out with people with disabilities, just get to know them, just kind of go have the proverbial beer with a person with a disability. I had a young person who's applying to medical school who works for the Special Olympics and has done that for years, because he said his godbrother is somebody who is a Special Olympics participant. And so it's just really meaningful to him that this is what he wants to do in his medical career, is focus on disability. And the other thing is, I think that we need to have more education about just basic things, about sign language interpreters. Being ineffective communication for people who are deaf or hard of hearing is one of the most common reasons for an ADA lawsuit. And a lot of physicians might not know about things like pocket talkers or other ways to kind of communicate with people who are deaf or hard of hearing. And so a lot of different things need to happen.
Right. I think the last question I want to ask and give you some time for is from, I think, some participants with disabilities, but also directed towards people with disabilities, which is to say, how can patients get involved and potentially do a better, more effective job of being able to advocate for themselves in these clinical settings? Is there advice or is there wisdom that you've gained either from your experience or from your research that it would
Yeah.
show like how to improve their own advocacy and participation in care?
Yeah, it's such a great question. And I mean, I've experienced it as well. I remember, um, you know, after I have a younger sister who was diagnosed with breast cancer, and I went to a new primary care doctor I had gotten, fortunately, because my old one had left. And I rolled in and she was taking a history, and I said, my sister was just diagnosed with breast cancer. She couldn't get me out of my wheelchair onto an exam table to do a complete breast exam. And so here I am, somebody who knows about this. And she was saying, and I just don't have enough time. I don't have enough staff. I couldn't advocate for myself, and so it's really, really hard to do. And it's especially hard to do if the reason that you're there is you feel sick. Um, Another reason it's hard to do is because this is a natural thing. Everybody wants their doctor to like them or wants other people to like them. And so you're not going to be a hard nose about it. It's just going to not come naturally to a lot of people, and to be kind of very stern about it. And so I think that I would just suggest the usual things that people talk to patients to empower patients about before they go to their practice for a visit. And that is to make sure that over the prior week, you're writing down all the things that you want to talk about. And my friend who's quadriplegic, gets in touch with me like a couple of days before he says his doctor and says, Lisa, here's my list of things I want to talk to her about. Can you think of anything more? And so you make sure that you just don't leave the doctor's office until you've gone through everything on that list and until you feel that you understand the answers to everything on that list. And one of the things that you might want to think about talking to your doctor about is, and some people, this is going to be okay for them, and some people it's not. But what time of day would be best for you to schedule your visit? Like if you're the last patient of the day, might the doctor feel a little bit more relaxed and willing to spend a little bit of extra time with you to be able to go over everything, as opposed to if you're the first person of the day, patient of the day, and they feel like, oh, I've got, 10 patients in my clinic, I need to really go through this really quickly. So there's a number of things that I think need to be thought about, but it's a great question. And it's something that I think, do you have a Center for Independent Living there where you are
I'm
in
not sure, actually.
Minneapolis? You must. I mean, you must have a CIL in Minneapolis. CILs are also really good places to go. And if your CIL doesn't yet have kind of peer counseling or training for how to interact with physicians, you should say to them, can we get together a group, and come up with some ideas for how to do this?
Great. Well, we're at time.
Yeah.
Thank you, Dr. Iezzoni. This is extremely important work, and we really, really appreciate your commitment and experience in sharing this with all of us. I think we have some final wrap up from the center. Kayleen, do you want to put up that last slide to talk about our next few events, and then we'll wrap it up. So just for everyone's information, we have a couple of events coming up. On February 14th, we have our next episode of Unpacking Bedside Bioethics. This one will be about informed consent. And we'll have two speakers, Miriam Shapiro, who is a pediatric intensivist, and then Thaddeus Pope, who is a national expert in bioethics and law. And then on February 24th, we'll have another esteemed and national expert that we have locally, Dr. Rachel Hardiman. She'll be talking about Black reproductive health and really to get a sense based on her research of the root cause of inequity in Black reproductive health. And so more information will be available, I think, at the Center for Bioethics website.